Dr. Connor, good morning.
Good morning.
Let me explain who you're talking to when you give evidence. Obviously, the people in front of you, but in addition to those, you're talking to those who are watching online, either YouTube or live stream, and there'll be 100 or so more people who are interested in what you have to say immediately. There are the lawyers who are sitting to your left, and representatives of the press in the far left-hand corner. The questions are going to be asked by Ms. Scott once Mary has invited you to take the oath. Mary.
Please state your full name.
Nicola Ruth Connor.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Yes.
Dr. Connor, I'm going to start by running through an outline of your career. So you attended the University and Middlesex School of Medicine and obtained an MBBS in 1991, is that right?
Yes.
And then between 1994 and 1996, you were a research registrar at the Public Health Laboratory Service, which I'm going to call the PHLS,
Yes.
Communicable Disease Surveillance Centre. Broadly, what did that organisation do?
Well, we were the Public Health Protection Service for England, and I was working in the HIV and STI department, so we ran the surveillance systems. So that's how we know how much HIV and sexually transmitted infections there are in the country. And we, more than that, the organisation as a whole protects public health, looking at outbreaks. You can see its role. I mean, now PHLS then more became HPA, became PHE, became UK Health Security Agency, but actually I've stayed in the same office in Colindale the whole time. So it's the same function of protecting public health.
And in 1996, you received an MSc from the London School of Hygiene and Tropical Medicine and took up a post as senior registrar, still at the PHLS.
Yes, they have a training programme.
In 1999, you became a Faculty of Public Health, becoming a Fellow in 2008. And is that the organisation that sets the standards for training, examination and specialist practice?
That's our professional body.
Yeah, professional body for public health specialists. And then in 1999, you were seconded from the PHLS to take up a role at the Department of Health as Senior Medical Officer for the Environmental Transmission Infection Unit. Is that right? Yes.
So I think I was coming to the end of my training and we were working on the communicable disease strategy then, and a secondment opportunity came up at the Department of Health, and that was a good opportunity.
But by November 2000, you had become the Senior Medical Officer at the CJD Policy Unit at the Department of Health, again seconded still from the PHLS.
That's correct.
And what was your role as Senior Medical Officer in the CJD Policy Unit?
Supporting the team there involved in running various committees that they ran and giving advice. To be honest, I found it quite hard to remember exactly what my role was now. It's about 20 years ago. But looking at the documentation, that's what I think I was doing.
And so it looks again from the documentation as though you were a member during that period, so November 2000 to February 2002, you were a member of the Department of Health Medical Research Council Research Advisory Group on TSEs.
It's more likely that I was being an official rather than a member.
And an official, what's the status of an official?
Attending meetings, writing minutes, making notes, communicating the decisions to other members of the policy team.
And then you noted as being an observer on the advisory committee on dangerous pathogens working group on TSEs. Is that a similar role to an official?
Yeah.
And you are, again, recorded in minutes as being a technical advisor to SEAC. Is that a different role?
Yes. Well, I'm just trying to think. I mean, again, it's hard without seeing the paperwork to remember exactly what I was doing, but it might have been things like helping prepare papers for them, that kind of role, supporting the Secretariat. Yes, it would be helping, making sure that the committee had the information it needed to make its decisions.
And then you also described as an official in minutes of the Chief Medical Officer's SEAC epidemiology subgroup.
Yeah, I mean, it's all the same kind of supportive role.
Supportive role, so not in the decision-making role, but in a supportive role to either the Secretariat or to the groups themselves.
Yeah.
And then in March 2002, you took up your role as head of the CJD team, presumably first at the PHLS, and then in 2003, when the HPA was formed, the HPA being the Health Protection Agency, you continued in that role as head of the CJD team at the Health Protection Agency.
That's correct.
And you were, at that stage, a consultant epidemiologist.
That's correct.
And you remained in that role until May 2012.
Yes.
So just pausing there in your CV to ask you some questions about the Health Protection Agency. You've told us that then became Public Health England, and then Public Health England has now become the UK Health Security Agency. So you've referred to those as PHE and UKHSA. So
yes.
that's what that stands for.
Yes.
Is it? Was the Health Protect what geographically in terms of the four nations? What was the remit of the Health Protection Agency?
England.
And what were the equivalent organisations in Scotland?
We worked. I don't know. It was then called. We worked with SCIA, a Scottish. I can't remember exactly what it stands for, but again, infectious epidemiology health. I can't remember what the actual acronym stood for. And now it's, I think, Health Protection Scotland. And we work closely with our colleagues in Wales and also Northern Ireland. So
there were equivalent agencies in those.
I'm just trying to think whether our remit covered Wales at any time. I think we were always working with Wales. It's hard for me to remember exact remits of the different organisations.
And the purpose of the Health Protection Agency?
I'm trying to think how it changed. At which point I think it was still pretty much the same, and I think it was when we became PHE that it became a much broader remit, including non-infectious diseases.
So the description you gave us in relation to PHLS applies equally to the Health Protection Agency?
From our perspective, yes.
And what was... I understand that the Health Protection Agency was what's called a non-departmental public body. So is this right? It wasn't actually part of the Department of Health, but it was funded by the Department of Health.
Okay, I don't want to give you incorrect information, so it would have to be in my understanding. We weren't truly independent of the Department of Health. It was more of an intertwined relationship. And I think we were a non-departmental body. We became an arm's length body at some stage. Then we became an executive agency. And actually, I don't really know the proper differences between these different things, but I'm sure there'll be someone else who can explain it to you.
And so is it right to understand that you received instructions from the Department of Health to carry out some task, for example, the notification exercise?
Okay, so I think that you're talking about is the relationship between also the CJD instance panel and the Department of Health, because the Chief Medical Officer set up the instance panel, and the Department of Health used to run the Secretariat for it before it was moved over to what became then HPA. So they would authorise, I'm not sure whether it would be an instruction or an authorisation of the recommendation, or how it would be to do that yes, they would fulfil, the panel could go ahead with its recommendation, more like that.
So that would come through the Chief Medical Officer or the Department of Health through the accepting the recommendation or advice of the panel, and then who would instruct the Health Protection Agency? The panel or the Department of Health? Or if you don't know?
I think it may have been the Department of Health, but I don't know exactly. Yeah, well, yeah, I'm not. It's probably the Department of Health. I can't believe it wouldn't have been the panel telling HPA what to do. It must have been the Department of Health giving us that role.
It may become clearer as we look through some of the documents. It may not. Returning then to look at what your team were doing, the CJD team. What was the remit of your team?
Okay, there were different pieces of work going on. So part of it, what I was doing was we were providing the secretariat to the CJD instance panel so it could run smoothly. We responded in a sort of more of a health protection way to any incidents and questions that came in from around the country. It could be from our local public health teams or from a hospital. It could be any, generally not from members of the public, this would be from the medical community generally, in dealing with some of the CJD health protection issues. And then we also had a team sort of following up people who were in the at-risk group, so running that kind of data surveillance. And then we had more of a sort of research team, well, it's not really different teams, sort of within the team, it makes it sound much larger than it was, running the prevalence studies, so tonsils, appendices, to look at the prevalence of CJD in the population. I think that probably covers our scope of work.
And we'll come and we'll be looking later this morning at some of the documentation that relates to, for example, following up those that are at risk in the community from CJD. In terms of the prevalence work, is it right that the Health Protection Agency set up the Tonsillar and Appendix Tissue National Archive?
That's correct. So I wasn't working on those areas, but I was working with people who were running those studies.
Was that headed up by your colleague, Professor Gill?
Yes, so Noel Gill, and I think Kate Solden was also involved with those, as well as more junior members of the team.
And can you give us an idea of the size of the team? Okay,
so I think it might be a bit more confusing than otherwise, just because I kept having, it was at the stage when I was doing maternity leave and childcare stuff, so people were covering for me. But in essence, there was myself, and there would be Noel, and I think he would have had another consultant supporting him on the prevalence work. And then there would be a couple of, maybe 3 scientists, and then we had a senior administrator and a junior administrators helping with the panel support. And we had a nurse as well working with us. She did some of the qualitative work. That was the rough size, so maybe six people, something like that.
And then in May 2012, you took up a post as consultant epidemiologist at the HIV and STIs, sexually transmitted infection division of the HPA.
Well, yeah, it's actually, I had the same post. So I got the consultant post in CJD, and I just moved responsibility. So the CJD team was within the HIV and STI team. Noel Gill was the head of the whole department, and I moved within his department from CJD onto chlamydia and HIV.
And that's a post you hold?
That's the same post I'm in.
Today. So I'm going to ask you some questions now about the notification exercise, and we've heard quite a lot of evidence about that yesterday. So I just want to understand the division of responsibility insofar as you understand it between the panel, the Health Protection Agency and Department of Health. So is this right, that it was for the panel, the CJDIP, to advise the Department of Health about whether or not notification should take place? And if so, who should be notified?
Yes.
And then it was for the Department of Health to accept or not accept that advice.
Yeah.
And we know that they did accept that advice. Yeah. And then it was for the Health Protection Agency to put into effect that decision, that notification, to effectively coordinate it and deliver it.
Yes.
And in terms of authoring documentation, working out how the process is actually going to work, the nuts and bolts of it, was that led by the Health Protection Agency or led by the panel, can you recall?
I think we generally, so are you talking specifically about the haemophilia, the plasma product notification in 2004? Or?
Oh, I mean, I'm talking generally now. So
we would have been the people coordinating how to do it, but we would work very closely with members of the panel. So, I mean, I can comment on yesterday if that helps. I don't know. I mean, so for example, in creating some of the information packages that we were putting out, I heard Professor Ironside give his talk that he wasn't particularly involved, but we worked very closely with him on other things from his pathology point of view, but we worked with other panel members. So we had public health representatives on the panel, we had lay people, we had a psychologist, we had GPs, we had a range of people who we would work with. We had someone from the CJD support network we had very good relationships with, who would help us create the documentation. And then we also, say particularly for the 2000, the haemophilia notification, work with the UK HCDO, Frank Hill, Charles Hay, and the haemophilia, I think it was their alliance. I just don't think what the name of the patient organisation was. So and likewise, similarly with the immunodeficiency groups, we had links with lots of them. That's how we created the process. It wasn't, we didn't sort of sit in a corner and go create it. It was how do we work with people? How do we get it?
And equally, you didn't have you weren't sitting in the full panel, CJDIP panel meetings going through line by line the toolkits, but you were going off and getting advice and help from people outside panel meetings.
I can't remember whether we sent drafts to the panel as we developed it, or whether, but they certainly would have. They definitely would have seen the documentation. I can't remember at what stage different members of the panel saw the process and got involved. And it would, as I said, it would have depended what their area of expertise. It was a multidisciplinary panel, so we would have worked more closely with some than others.
And just in terms of trying to understand the time frames in which everything was taking place, we heard from Professor Ironside that there was a period of consultation in October 2001, and we know from the papers, which we can go to if necessary, that the framework document was provided to the chief medical officers in October 2002. Do you know why the chief medical officers were asked to approve the framework document and the working, or the way that the panel was going to work?
Well, so that's in 2002.
October
so 2002. It was. So the Secretariat was still within the Department of Health at that stage, or had it moved over?
I don't know the answer to that, actually.
Given that the CMO set up the panel, maybe that was an expectation, and that government would approve it. I mean, in a way, I was thinking that in some ways it's a bit like the COVID response you can see now, that here is a recommendation to take a public health action that could be difficult, or can have, clearly it could protect public health as the risk is a bit uncertain or very uncertain, and there could be negative consequences to the public health action. So could be seen as a political decision, so it ought to be taken by CMO or government as to whether it goes ahead.
We, again, we can go to the documents if necessary, but the inquiry, I know you've looked at some of the CJDIP annual reports, which set out that the 4 CMOs responded to the proposals in the framework document in June 2003. Does that ring a bell with you?
I'm sure if it's in an annual report, it's correct, yeah.
And then the framework document was published, and I suggested to Professor Ironside that it was in December 2003, but having looked again at the annual reports from the panel, it looks like it was March 2004. Again, does that period of does that sound right to you?
I'm in the same boat as you. That the only way I would know exactly what data was published is by looking through these records to look it up. So I'm sure if you've seen it in the documents, it would be recorded correctly. I do remember that there are iterations of the framework document because they were incredibly keen to get it out so they could get moving, but there was still delay of what to do about some of these blood issues and the plasma product. They all do the risk assessments taking a long time and having to get redone. I think they discussed in previous things. So it was like, well, can we put it out and just have some bits greyed out, so you can put out at least part of it as a way of getting past the sort of the blockage, not really a blockage, but the fact that it was taking longer than we wanted.
Yes, and certainly with Professor Ironside, we looked at a version that was dated December 2003. But yes. I'm going to take you to a meeting of a minute from March 2001 to try and understand your evidence about what happened in that interim period between the panel being set up and the framework agreement being published in, it looks like, March 2004. So it's DHSC 002 0723 _087. Now, this is a draft minute of a meeting to discuss incident number PI 37, incident involving blood and blood products from 26th of March 2001. And we can see that you're at the bottom there listed as the panel secretariat. Now, it's not entirely clear from this whether or not this is a CJDI panel, incident panel meeting, but is it right that is the PI 37 is a panel reference, and those people attending, certainly the chair and so on, were members of the panel, or some of them were members of the panel?
It looks like a subgroup or something, although it's only a draft minute, I see that, so it's not a final minute.
And if we look at paragraph 2, we can see why the meeting's been called and what the incident is, and it's the incident involving blood products derived from pooled plasma, which included plasma donated in 96 and 97 by a person who later developed VCJD, and the possible size of the cohort could be up to 40,000 patients, and the query about whether or not the donor's blood may have been used in labile blood components, but that hadn't yet been confirmed. And then if we go please to paragraph 4 or paragraph 5 over the page, we can see that the current NBA policy is set out, NBA being the National Blood Agency, and they consider it ethically unacceptable to take a donation knowing that it will be discarded. So if somebody presents to donate blood, not accepted as a donor, they'd have to be told why. And it says, at present, pending guidance from the panel, the NBA has a list of names of individuals who have been identified as recipients of blood components originating from donors who have later developed VCJD. These individuals have not been informed of the situation but it's considered wise to ensure that if any of these individuals presented as donors, their donation would not be issued for use. And Dr. Hewitt gave the inquiry evidence in relation to that issue. And then this meeting seems to be, although it's not entirely clear from the minutes, discussing the interim guidance, or interim guidance from the Deputy Chief Medical Officer. And we can see at the bottom of this page conclusions to be taken on into the draft guidance. It was explained that based on epidemiological evidence, fractionated blood, i.e. plasma products, would have only a low risk of level of infectivity. It could also be hard to identify all recipients of fractionated blood, as tracking was not necessarily in place for this product, and whole blood and blood components were not considered to be a low level of risk. And then if we go over the page, we can see at the bottom there, there is a heading, comments on the draft letter from the Deputy Chief Medical Officer, and a range of comments are made in relation to that. And then summary of action points at the bottom, second one down, Charles Lister to redraft letter from Dr. Pat Troop. Now, it's not entirely clear what's going on in this minute, but what I wanted to ask you, arising from this, is two issues. First of all, it looks like in this meeting there is a discussion about interim guidance being drafted by the Deputy Chief Medical Officer, and you, I understand, heard the evidence of Professor Ironside yesterday when we looked at that document. He couldn't recall discussions about that document. Can you recall whether or not such interim guidance was issued?
No, I mean, it's so hard. I mean, because, so much of the way I was able to answer all the questions you've given me is because I've still got access to all my documents, because I still work in the HIV and STI department, so I can see. But I don't know, because I don't have access to all the DH documentation, so you'd have to ask someone within the DH what was done.
So you have no recollection of that. And then the second issue that I wanted to ask you about was in relation to the conclusions that we looked at on the previous page about the risk from blood and blood components. So paragraph 11 there. Paragraph 10, conclusions were that it was fractionated blood, i.e. plasma products, would only have a low risk level of infectivity, and then whole blood and blood components were not considered to be of a low level of risk. And I wanted to ask you, I wanted to take you to another document and then ask you a question in relation to that point. Could we look, please, at SCGV 301019_073. Now, this is a document we looked at with Professor Collins. It appears to be a information sheet for patients exposed to variant CJD through blood components from the Health Protection Agency, December 2003. And it says, why are you contacting me? A patient has been diagnosed with VCJD, probably caused by a blood transfusion. This patient received blood donated by a person who later developed VCJD. This is the first time that this has happened. Some other people also donated blood before they became ill with VCJD. You have received blood donated by one of them. So this appears to be the patient information sent as part of that December 2003 notification to those who had received implicated blood components. And then what I wanted to ask you about was the paragraph, do I need to know about this? And it says there, the risk appears to be very small, but it's important that you know, even though this may regrettably cause you anxiety. And then a little bit later on down the page, it says, am I a risk to other people? there is a small possibility that VCJD could have been passed on to you. If this happened, then likewise you could pass VCJD on to others in certain circumstances, and then it sets out the public health precautions that should be taken. Now, in light of the meeting minute that we've just looked at, do you know why the messaging in this leaflet was as it was, that there was a small risk it's identified as?
Okay, so I became aware that you were interested in this issue when I saw Professor Collins on Friday do his thing, because that wasn't in my kind of Rule 9 set of questions. But what I did after that was I was trying to look at these what records I could find about the information that we'd sent out over the years to patients or people who were being told that they were at risk of CJD. And what I could see was from the 2003 notification, when there was one possible transmission, the language used then was changing as the evidence for transmission grew, and the second, third, fourth transmissions came to light. So, I mean, it would have been gone over unbelievably carefully, the wording about how to do this. It hasn't been done before, and people, I mean, it's interesting, because if you look at the framework document, it does show the thinking of the panel and not wanting to scare people witless, and yet wanting to get them to take a public health precaution. It was a very difficult message to put across, because the panel was very aware, and we're all very aware, that this is a very scary thing to tell people. And so how do you put this in how do you actually write, what words do you use was very difficult, and people thought long and hard about it. And you know, so I'm looking at that thinking, well, okay, that's what we said at the time, and you think, well, I can see by 2005 actually the language had changed, and you know, then people were saying, you know, so I think that was the balance that was struck then, and it was felt right at the time. And as evidence grew, and what we changed the message. That's all I can really say.
And we'll come on to look at some of those later documents in a moment. But is it right? It's right to understand then that the focus here was to ensure that those that were being contacted would take public health precautions, don't donate blood, don't donate organs or tissues, and tell clinicians if you need surgery. But the focus wasn't, and I think this is what Professor Collins's concern was that the focus wasn't on ensuring that the patients understood that they actually should probably go and have specialist referral, and be under the clinical care of somebody that knew about VCJD.
Well, what was felt quite strongly was that it was kind of how do you support, what's the best mechanism of working really with this small group of patients? And many of them were very elderly, so we've got people in their 70s, 80s, 90s. So, and some people, you know, because we were liaising with their GPs, we knew that some people were more vulnerable than others. You know, so we agreed that actually the GPs should be the kind of holding gatekeeper, as it were, so that we knew that some patients, or some of these, some people just wouldn't want to know and would have the right. So in a way, that was kind of the ethical discussions within the panel, to say, thank you very much, I don't want to get referred. So I think the discussions were very much going to be via the GP, and that was the kind of liaison, and that was the process that we developed, so that then we gave people contact details of the prion unit and the surveillance unit, and the GPs would, were aware of it, but we didn't. It was felt right that patients could very much choose what they wanted to do with this.
And so key to that strategy is that the GPs understand what the risk is and understand what VCJD is, so that they can give proper information and advice to their patients. Is that right?
Yeah, so we set up, I mean, again, this came out, it was something from that I think you were talking about with, I can't remember whether it was John Collins or James Ironside, but this, how do we support people? So obviously the public health members of the panel were there. We have a relationship. The way the organisation HPA is set up is that we have a relationship with our local public health teams. So there are local public health consultants covering each area, and they will often work with GPs on health protection issues, an outbreak, or whatever. So that there's a relationship. That's the way we relate, and we, in addition to that, we set up this, what we called a cadre of experts. But basically, I think I sent it out to, I think you've got the document, which is basically, we developed this sort of virtual, well, it wasn't virtual then, it was a team of people from counsellors or nurses or doctors from the prion unit, the surveillance unit. We also worked with the Institute of Child Health because they had experience through human growth hormone, and we had GP. We had a range of people who were there also to support local teams.
And the document reference, we don't need to look at it, which sets out the list of those people in that cadre of experts is PHEN 302466. And how was it anticipated that these experts would be accessed by the GPs?
They would come through us at Colindale. So because we didn't want to sort of issue everyone. So, well, there are two ways, actually. If any GP wanted to directly contact the prion clinic or the surveillance unit, they could, or us in Colindale, they could do so. And if they wanted some sort of advice over the sort of counselling or whatever particular questions that a patient had or something, then we could put them in the direction of of this list of people that we had access to.
And were the GPs informed that this list existed, that this was a
I can't remember if that was established by the time at 2003. So it may. I'm trying to think, because the document I found was, I think, from 2005, or so. I'm not sure. It may have been something that we had more informally, or we just directed people to the units. But I'm not sure. I suspect it was a slightly later date, just because that's the date of the document that I saw.
And just for the transcript, the date of the document that I read the URN out for is the 22nd of July 2005. Can I take you to a document from December 2003, NCRU 40180_010. Now, this is an inter-office memorandum, and it appears to be an inter-office memorandum for the National CJD Research and Surveillance Unit. So I know the inquiry sent it to you, but presumably you hadn't seen this document before the inquiry sent it to you. And it sets out, it's from Richard Knight from the Surveillance Unit, and it sets out a record of the details of a conversation that he had on the 29th of December from somebody who phoned to speak to someone in the unit because she'd been notified that she was a recipient of VCJD blood and wanted to discuss the implications. And in that first big paragraph there, she said she told me she had been asked to contact her GP as a matter of some importance, and eventually had an appointment with a doctor that she'd not seen for 7 years on Christmas Eve. This doctor told her that she'd received a blood transfusion from somebody who had had variant CJD. She said that she was informed that they did not know whether the donor had had the disease when he donated and were not able to give her a lot of information, although they obviously tried quite hard to deal with the matter sympathetically. When she asked what would happen next, she was told that she would obviously have to wait and see whether she developed the disease. She obtained information as to the symptoms of variant CJD and was a little bit concerned as she herself had suffered from depression and also had some painful symptoms in her legs. Following this, she said that her legs became more painful, but she thought this was probably because she was worried. The news obviously cast a very bad shadow over the Christmas period. And then she goes on to say she received a leaflet, which was apparently from the HPA, and the leaflet was dated December 2003. At the end of the leaflet, she stated that it simply said if she wanted information, she could contact one of 4 numbers. That was then a list with the National CJD Surveillance Unit at the top, Department of Health second, CJD Support Network third, and the MRC Prion Unit fourth. She decided to contact ourselves because our unit was at the head of the list. And then he goes on to say that he spoke to her at some length, and he raises a number of issues. If recipients are to be told about their previous transfusion risk, I think they should have some organised method of follow-up discussion. I would have thought that the National Blood Authority would have provided some form of organised access to information and discussion. Then if we go over the page, in my view, such further discussion is best undertaken face-to-face and not over the phone, and is best undertaken when some background information about the individual concerned, including, of course, the reason why they had blood transfusion and any other relevant past medical or personal history. And if we are indeed to be one of the principal sources of help to such individuals, this has been arranged, as far as I am aware, without any consultation with us, and certainly I personally was not notified of this in advance. And again, if we are to be involved, it would be very helpful to have a copy of the leaflet that has actually been given to those individuals, so we could at least see what is being said in this. I personally have never received such a document or seen it. And he says, makes the point, it's all rather unsatisfactory. And then at the bottom, he says, you will know that when the discussions about notification first took place, I personally was in favour of the policy of not notifying individuals. This is primarily on certain grounds of principle. However, I did make a number of practical points, and one of these was a concern as to whether or not proper follow-up discussions would be organised with individuals who were notified. This recent contact rather suggests that my concern was a reasonable one. Were you aware in December 2003 that this was the position of the Research and Surveillance Unit, that they hadn't been effectively, weren't really on board with how the notification process is going to operate and their part in it?
I'm trying to think. So Bob, Will and James Ironside were members of the panel, I believe, at that stage. Richard Knight did become a member of the panel, but that may have been later on. I'm not sure. So it may have been that some of them knew, but not everyone knew. And I mean, it's really bad actually reading about that. I feel very sorry for the lady. So I think, yeah, so obviously you look at that and you think, oh gosh, well, you want to have done that better. It's actually my reaction to hearing you reading all that out. So Richard, he said he wasn't in favour of notifying individuals. Yeah, I mean, but so I don't know. I mean, what's the question?
Well, I think the question I asked was whether you understood that this was the position taken by the Research and Surveillance Unit, and I think what you've told me is, well, actually there were 2 members of the Research and Surveillance Unit on the panel, so certainly they would have known what the position was.
It's hard to believe. I mean, Hester Ward, Bob Will. I mean, you know, it's hard to believe that they didn't all know what was going on. I mean, I mean, the thing about that notification, I think it was driven by the fact that that's when Secretary of State made the announcement and that case was identified shortly before Christmas. I mean, it's always terribly, you never want to do anything like this over a Christmas period. It's not ideal in any ways, and that would have been the reason, is that it was going to come out in the press and you had to tell people first. I mean, in a way, may I diverge to what you were talking to James Ironside about yesterday, which was the plasma product notification, which this idea that you could sort of do it in a staggered way, but it doesn't work like that, because once things are out in the press, people get terribly worried and terribly upset that they haven't been told by their doctor. So you have to, however difficult it is, you have to make sure that you've had that contact with people before things get into the media. Otherwise it becomes even worse, and then people get worried that they haven't been told, and why weren't they told? So.
I'm going to now look at the further communications with this patient group. So sticking with the group of patients who were notified in December 2003 as a result of having blood and blood components. PHEN 302406. So this is a letter from the Health Protection Agency dated 6th of February 2006 to a what looks like a GP, and it's in relation to a patient, and it says this: it's now just over 2 years since this patient was informed of their potential exposure to VCJD via their blood transfusion in 1998, and of certain precautions they are asked to take for public health purposes, and then sets out what the purpose of the letter is: to give you fresh news on the risk that your patient may develop variant CJD, ask you for an update on the clinical status of your patient, advise you and through your patient of an invitation for evaluation at the National Prion Clinic sent under separate cover and other options for specialist evaluation, and to inform you of proposals for research that your patient may be asked to volunteer for. We have written to you previously about this patient. If your practice is no longer responsible for this patient, please would you let me know. So just pausing there, is it right to understand from that last paragraph I've just read out that there would have been communications between the December 2003 notification and this February 2006 correspondence with the GP surgeries of those that were notified? Is that your understanding?
I believe so, because yes, we would have contacted them at least when... that was in 2006 and 2004. So, yes, I mean, I haven't got the chronology here. I can see that was Kate Solden's letter. So, yes, we would have been getting updates and checking.
And certainly you carried out a... you got some feedback from the GPs following the notification, didn't you?
Yes, we wanted to ask them how it went.
And so we can see here that the multiple purposes of this letter, more news about the risk, and then 3 and 4, the issues that Professor Collins had been raising. Is this right? That Professor Collins told us that he had been raising these issues with the Department of Health and with the Health Protection Agency, that he wanted to ensure that the patients really understood what was available to them. And so was that a driver for this letter?
Yes, well, we wanted to, and I think some ethics approval had come through for other studies. So I'm sure it would have been in collaboration. We work with John Collins, but also within there was another neurologist, Simon Mead, in his unit, who we work quite closely, and we always have this issue of again, this balance of wanting to respect people's autonomy and therefore going through the GP, and yet recognising that it was super important to encourage people to have postmortems and give samples and do everything else, but yet respecting their wishes that they may just not want to, it's too scary to go there, kind of thing.
And then we see at the bottom of the page that information is given about the third case of VCJD infection, and right at the bottom, that last sentence, it's messaging about the risk. This case further increases the level of concern about the risk that variant CJD may have been transmitted to patients exposed to implicated blood. And then if we can go over the page, and we see halfway down the page, if we go a bit further down, please, where it says, we believe it's now appropriate to ask you to consider referring your patient for specialist evaluation, and sets out details of the National Prion Clinic. And makes it clear that the referral decision form should be sent via you. So the idea was that if there was to be a specialist referral to the National Prion Clinic, it would go through the Health Protection Agency. Is that right?
I think, no, it was more that we wanted to know what they were doing, and while we couldn't tell them, we weren't telling them to refer, but that in our language would be quite a strong recommendation, and please let us know if you haven't and why not, kind of thing.
And then a leaflet was sent with that, which we look at, which is PHEN 302415_002. So information for patients, February 2006, and it sets out that it's information for those patients who've been informed by their doctor that they are at risk from having blood transfusions. And then if we go over the page, please, we can see under why am I being contacted, the second paragraph there. Medical records show that you have received a blood transfusion from a donor who later developed VCJD. It's therefore possible that VCJD could have been passed on to you through your blood transfusion. And then if we go down to paragraph 4, does this mean I'm going to suffer from VCJD? You have been identified as being at risk of VCJD. This does not mean you will definitely develop VCJD. The risk of this happening is unknown. It's impossible to put an exact figure on the chances of getting VCJD, either from BSE infected beef and beef products, or the possible additional risk from receiving a blood transfusion from a patient who later develops VCJD. To date, 3 patients out of a relatively small group of patients who have been transfused with blood from donors who later develop VCJD have been found to have evidence of VCJD infection. 2 of these patients have developed VCJD disease, and go on to give the details in relation to that. So it's right to understand, is it, that the messaging has changed by February 2006 from a small risk to, well, we don't know what the risk is, but these are the facts, that out of a small group, so many have been infected. And then there are other documents sent, and I'm not going to go to them, I'll just read them for the transcript. In another example of a document being sent by the Health Protection Agency in January 2007, PHEN 302465, and correspondence sent in February 2011 about Professor Collinge's direct detection assay, his DDA test, PHEN 302385. So the Health Protection Agency is keeping in touch with these patients through their GPs. Is that how it worked? I'm going to move then on to the September 2004 notification. So the notification for those with bleeding disorders and other patients who had received plasma products. Again, just to try and understand the how the process worked to begin with, can we look at DHSC 6710801? And we heard a bit about this from Professor Arnside. I don't want to go over that with you, but this, I want to ask you about the input from the Department of Health, and so I'll show you at the bottom of this page, bottom half of this page, we can see that this is an email from Nathan Moore dated 23rd of July 2004 to Professor Gill, and it seems that, I'm not sure whether you've been copied in or whether it's to you, it's a bit unclear, but I think it's actually to you rather than you being CC'd in. But it says this: we received a response from Minister on the plasma product submission, and the Minister has agreed, and then it sets out the details, so agreed to an umbrella approach, and then if we go over the page, we just can deal with this quite quickly. Informing clinicians, treating people with haemophilia, informing people with haemophilia and other bleeding disorders, ensuring the NHS traces products, implicated products, and the communication strategy. And then the Minister makes a point about there not needing to be that the notification exercise doesn't need to be put in the public domain by way of a press release, and then now ensuring that the notification exercise moves forward as planned. And I just wanted to ask you about the fact that the Minister appears to be getting involved in the detail of how the notification exercise was undertaken. Was that how you recall it?
I actually don't remember this email. The only thing that they're saying really is it's all fine except for don't do a press release. Is that right?
Yes, I think that's right.
That would be. I wouldn't. That would be a sort of. Yeah, the DH might well have that kind of thing. We often, our press office and their press office would often have discussions about lots of things, about who did a press release, what, how the sort of comms side of things worked. So.
So there's nothing surprising there to you?
It sounds like a general. What I can imagine is the officials sort of said to them, "These are the plans," and they're saying, "Yes, fine, but just this little bit we don't want."
Can we then look at how the sort of mechanics of the notification process by looking at the report that the Health Protection Agency gave to the panel about the notification, and that's at WITN 709 1004. Now, we can see this is the report from the Health Protection Agency, and it's not authored by you. It's by Anna Molesworth and Angie Bone, and it's dated the 19th of January 2005, final report.
So, Angie Bone, she's another public health doctor in the team, and Anna Molesworth is a senior scientist who's actually, I think, gone on to the surveillance unit. So, yeah.
Can we turn, please, to page 6, where the process is set out? And if we can just run through the process. So this is how the HPA identified the process. First of all, identify VCJD cases who were blood donors, and that was for the surveillance unit and the blood services. Then trace blood donations and use of components, inform fractionators of implicated plasma sent to them. That was for the blood services. Trace batches of plasma product made from implicated plasma, collate batch-specific manufacturing details for the UK plasma fractionators, and then estimate the potential infectivity of each batch of implicated product and dose equivalent to 1% risk of VCJD infection. And that's for the Health Protection Agency. And then you set out there, or you don't, but the HPA sets out there how they've undertaken that exercise. And then the next action is identify patient groups likely to have received sufficient product to be considered at risk. And again, that's an action for the Health Protection Agency. And it says there, following the precautionary principle, the entire period of possible exposure to VCJD through plasma products was taken as 1980, when BSE is thought to have entered the human food chain in the UK, to 2001, the last possible expiry date of any plasma product manufactured using plasma that was sourced from UK donors until 1998. And then if we miss out the next paragraph, we can see that by comparing the threshold doses of the implicated batches equivalent to a potential 1% risk of VCJD infection with the range of doses recipients were likely to have received in clinical practice, the patient groups likely to be affected were identified. So that's identifying the patient groups, and that was undertaken by the Health Protection Agency, is that right?
Yes.
And then if we carry on down the document, we can see 4.6, stratify risk of implicated batches according to the likelihood of a recipient crossing the at-risk threshold. And so there, the panel's recommendation, and we went over this briefly with Professor Ironside yesterday, that implicated products should be divided into high-risk products, so those batches that could be traced, that should be traced, and the individual recipients considered at risk for VCJD public health purposes, medium risk, where efforts should be made to trace those batches and to assess the potential additional risk to individual recipients, determine if special precautions should be taken for public health purposes, and low-risk product, where those batches do not need to be traced and the recipients do not need to be informed, and then some detail is added in relation to that. And then the next action is at 4.7, develop a strategy for the management of each patient group, and that's the Health Protection Agency and SCIEH.
That's a Scottish equivalent of us.
And so what's set out there is that patient group management strategies were developed through negotiation with professional and patient group representatives with the aid of expert opinion of condition-specific professional representatives, the UK National Blood Service, the NHS Trust medical directors and pharmacists contacted through the HPA CJD Incident Panel Network, and arrangements were made for those patient groups based on the likelihood of surpassing the at-risk threshold, the estimated number of patients possibly affected, the feasibility of identifying batches, and the main patient groups are then identified, and they are patients with bleeding disorders, patients with primary immunodeficiencies, and other patients. And then it sets out the arrangements for patients with bleeding disorders, and we looked at this with Professor Ironside, so I don't need to go into this in any detail, but and you've already told us that the UK HCDO and the Haemophilia Society were involved in the decision to have an umbrella notification for all those patients with bleeding disorders who have been treated with UK-sourced pooled factor concentrates or antithrombin between 1980 and 2001, because they should all be considered at risk and asked to take public health precautions. And then if we go over the page, we can see the other two groups, and I wanted to ask you about the third group, patients with other conditions. The remaining patients were cared for by different specialties and without a condition-specific professional organisation, where treatment with plasma products may well have been off-licence and batch information may not have been as rigorously recorded as for the groups above. An estimate of the expected numbers who may be considered at risk was not possible. The only way for these individuals to be traced and their potential exposure is assessed was through the NHS hospital trusts. Informal feasibility studies by representatives of the UK National Blood Services and SCIEH and discussions with medical directors and pharmacists suggested that there would be great variability in the ability of trusts to trace implicated batches to individual patients and assess potential exposure. But despite potential difficulties, it's considered important that such efforts should be made, although only where batches were traceable and recipients could be easily identified as having received implicated batches, would the traceback effort be considered proportionate to any possible public health benefit. And so this is the way that it was done. Is this right? Clinicians would be asked to forward individual batch exposure details to the Health Protection Agency for assessment of whether the patients should be considered at risk. So hospitals would know which batches were implicated. They would search through their records. They would say, yes, we've had these batches and we gave them to these patients. This is the amount this patient has had. and then you carry out a calculation to see whether it crosses the threshold.
That was the plan, and as it sort of says there, that the problem was back in the 80s, hospital computer records were not great, and variable, so lots of them couldn't trace, but we did what we could.
And then if we just pick that up, please, on page 14, we can see at 4.10, trace recipients potentially at risk and assess at-risk status according to the patient group strategy. Inform at-risk recipients of possible exposure and the public health precautions they are asked to take. If we say the assessment of potential additional risk and notification of at-risk individuals amongst patients with bleeding disorders and primary immunodeficiency is being managed by the clinicians providing their care under the separate arrangements in place for these patient groups. For other patients, clinicians were asked to forward patient exposure details to the HPA CJD section for assessment. The total estimated potential risk for individual recipients was calculated by multiplying the batch-specific potential infectivity per unit dose by the total cumulative dose of that batch received and summing the resulting potential infectivity doses for all batches received. And that was presumably for those patients that had received what had been termed medium risk product, i.e. if you'd had enough of it, you would reach the 1% threshold.
That's correct.
So that's why the individual calculation for the individual patient had to be undertaken.
Yes.
But if you were somebody that had taken what's called a high-risk product, so factor 8 or factor 9, where one dose was enough to get you over the 1% threshold, that individual calculation was not undertaken for you.
No, I think they were just able to find out if they had received an implicated batch. I'm not sure that there was I don't know if there was a sort of, you've received X number of batches. Can't remember the level of detail that was provided to patients if they asked.
And then we can see the outcomes on page 15. By the end of December 2004, a total of 9 UK plasma donors are known to have developed VCJD. Collectively, they have made 23 blood donations where the plasma has been used to make plasma products. The donated plasma has been used to manufacture a total of 187 batches of plasma products, comprising factor 8, factor 9, antithrombin, intravenous immunoglobulin G, albumin, intramuscular human normal immunoglobulin, anti-D, and 13 batches of plasma fraction intermediate. And then it sets out that those products have been supplied to the UK and to 12 countries overseas. And then if we go over the page, in fact, sorry, can we go back, to patients with bleeding disorders? Within the UK, an estimated 4,000 patients with haemophilia A and B and von Willebrand's disease in the UK would have received UK-sourced plasma-derived factor 8 and factor 9 during the period 1980 to 2001 and therefore be considered at risk. It was considered that a few patients with congenital antithrombin deficiency would have required treatment with plasma-derived antithrombin. It's understood that all these patients have now been notified via their haemophilia doctor of their at-risk status. Individual exposure assessments are being collected and managed by UK HCDO in collaboration with HPA. So just on that last paragraph there, what do we understand to be the individual exposure assessments?
So I think where we were talking about were when I said earlier what was the information we were collecting on the... So while the umbrella approach covered the information that was given to these patients and the precautions, there was still a collection of information to see what they'd actually received in terms of implicated batches. So that's, I think, what that refers to.
So,
I think.
Sorry.
Yeah.
So certainly the information that that group of patients with bleeding disorders received was you're at risk of VCJD, you must take these health precautions. If you want to know whether or not you've received an implicated batch, you can find out. So they would presumably be told, yes, you've received one or you haven't. This here is suggesting that there are is this suggesting that some other kind of assessment is being collected?
I think, I mean, again, I'd have to look at the whole other documents. I think what that is just the same sort of thing as this person has received 6 batches, this person has received 2 batches. The other point that is worth making, I think you covered this with James Ironside yesterday, about why the umbrella approach was taken. I think also it's thinking back. I mean, now we can say, okay, there was relatively few cases of variant CJD, whatever, but compared to what people were worried about. But at the time, a big argument was they thought there might be a lot more notifications coming through the pipeline. We thought there might be many more blood donors being identified. And so it was the idea of not having to go back again to people to constantly enlarge the group. And also, I remember conversations where the thing that actually, I think community might be too strong a word, but the fact is that if the information you're giving, that there would be a shared understanding between different families with haemophilia patients, that you want to make sure that you've got a clear message that avoids confusion and different messages, different people.
And then if we go over the page, please, to see the outcomes for the patients with other conditions at 5.4. By the end of December 2004, a total of 73 traceability questionnaires had been received from NHS trusts, of which 53 reported having received implicated plasma products. Of those, 16 reported having been unable to trace the recipients of these products. So does that mean that were traceability questionnaires sent out to every single NHS trust, and you had 73 responses?
I'd have to go back through these things. If they were able to identify which hospitals had received the plasma products, they would have sent them to those hospitals. I'd have to check the documentation to see if that is what actually happened. I
think we'll come on to see that that's what happened in later notifications,
right.
But I'm not aware of any. I haven't seen anything.
I mean, this would be the report that would explain it, and if it doesn't.
And then it says, by the end of December 2004, the HPA CJD section had undertaken a total of 1,826 individual exposure assessments for patients suffering from other conditions, of which 0.7% or 12 had sufficient potential exposure to VCJD implicated plasma products for patients to be considered at risk for public health purposes. So in that September 2004 notification, you have a very large group of people with bleeding disorders being notified. You have the group of people with primary immunodeficiencies, which we haven't looked at, and then 12 from this third other group of
right.
patients. So I note the time, and I've finished asking questions about this document, so I wonder whether now is a good time for a break.
Yes, I'd just like to ask one set of questions first, if I may. The idea of the notification was in part aimed at protecting public health by preventing people who might have prion disease passing it on through blood. Is that right?
Yes.
So the concentration on plasma was because plasma was the fraction of the blood which might, or would be, probably, most likely to convey the prion.
The plasma products?
The plasma itself, the product is made from plasma. And so plasma is the implicated portion of blood.
Right.
For protection of the public, the precautionary principle, you began, or the policy was to begin at 1980 and work through. Now, in the early 80s, at any rate, before leukodepletion came in the very end of the 90s, there were groups of people, such as those with thalassemia, those with sickle, those who had treatment for leukemia, who might regularly receive transfusions of whole blood. That would contain plasma, presumably, and if the plasma had infection in it, it would transmit or be likely to, or possibly could, transmit that infection. So it might be thought that those groups were also potentially at higher risk, might it?
People who've received other blood components.
Regular transfusions, because they needed them because of their condition.
I think there was a discussion about people who've received blood, but we couldn't put everyone.
Obviously, single transfusions are in one class, but these are multiple transfusions.
Yes. Sorry, you now. Okay, so later, later on, there was a discussion about people who were called highly transfused and very highly transfused, and because I think this is what you're alluding to.
Is.
And this was the subject of a lot of debate about what to do about managing these groups. And I think that was part of my Rule 9 thing, was about what we call a pre-surgical risk assessment for people who'd received 80 or more blood transfusions. So that was a policy that we did, that was a recommendation from the panel, and that was something that was done so that, because they weren't going to be blood donors at that, they weren't allowed to be blood donors, so then the risk that you're trying to mitigate is about surgical instruments.
Yes.
So we tried to have something where there's a pre-surgical risk assessment, so people coming up for eye or brain surgery, so the high-risk tissue surgeries, and they could be asked about their blood transfusion history. And then there was another assessment of this policy some years later. I think we're now talking 2012. I'm not sure exactly what year this is in, where they actually said the implementation didn't work. It hadn't actually worked. They weren't being picked up before surgery, and it wasn't actually being implemented and protecting public health in any way. And then and then the risk assessment changed again, I think, to 300 plus donors. I mean, this is again a little bit after my time on CJD, about whether they would change the risk point about how many blood donations you had received. And again, as the blood risk assessments changed, then the management ideas changed. Because originally there had been a decision about, there'd been a question about what do you do with people who've received 800 or more blood transfusions, again, the sort of things that you're talking about. And I don't think a decision was ever made on this, because they thought they'll tackle the, in inverted commas, the one that was easier to manage, because it became, there were so many, once we just started talking to haematologists about this, you then realise there are so many practical issues about informing patients. What do you do with someone who you know has got a condition who might one day receive this many blood transfusions, and what do you tell them? So that it became a very complex issue. So it wasn't that the risk wasn't discussed, it was discussed, and there was risk assessments about the issue that you're raising, but the actual application and what you do about that risk was quite problematic. I don't know if that answers.
Well, it certainly informs it, and I'm grateful for that answer. Some of that, I think, is reflected in what you say in your statement, but the question really arises in my mind, in part. It's plain from your answer that no one thought of this at the time that they were concentrating on plasma products, because the document we just passed off from the screen is all about plasma products.
And
the risk might be thought at this stage, in the early 2000s, to be something which is transmissible by blood, and that then might lead on to thinking, why didn't people pick this up earlier?
I can't remember at what stage the highly transfused issue was raised. I mean, I know it's in some of the documents, so we could have a look. But you're right, at that stage it was very much tracing, well, with our work was tracing the individuals and who were either donating or receiving blood or blood products. And there was already a thing that if there was a separate thing about people who'd received blood donations not then being allowed to donate. But you're right, the surgical risk was not related to people at that stage, to people who'd received lots of blood, per se, with no implicated donor involved. That was a later thing.
Yes. Well, I'll leave it there anyway for the moment, and we'll take a break until 10 to 12. Now, this is the first of the breaks. You may have heard, since it seems from your evidence, you may have watched some of the evidence of others. I do say to all witnesses at this stage that you're giving evidence. What you must not do is talk about the evidence you have given, or any evidence you think you may yet be asked to give, with anyone, whoever that anyone is, but you can talk about anything else you like. I'll see you back at 10 to 12. 10 to 12.